Hi, good morning, everyone. I'm very excited this morning to have Dr. John Levine from the Department of Hematology and Oncology joining us here for Grand Rounds today. He is a professor of internal medicine and pediatrics, and he trained in pediatrics at Children's Hospital of Los Angeles and in pediatric hematology oncology at Memorial Sloan Kettering. He then went on to spend 20 years as a clinical scientist at the University of Michigan bone marrow transplant program. And while there, he oversaw a clinical and translational research program that focused on graft-versus-host disease and developed a biomarker-based blood test that predicts response to GVHD treatment. In 2015, he moved across here to Mount Sinai in New York to join the Mount Sinai Acute Graft-versus-Host Disease International Consortium, or MAGIC, that conducts clinical trials and studies in over 700 patients annually from North America, Europe, and Asia. Now, in GI, we often enough get consults from the bone marrow transplant service for graft-versus-host disease evaluation. And it's an area that me personally, as a fellow, I feel like I haven't gotten a tremendous volume of experience from it. And then I'm really interested in learning the practical aspects of how to approach biopsy, diagnosis, and surveillance of these patients. So thank you very much, Dr. Levine, for joining us this morning, and this floor is yours.
Okay, great. Well, thank you for the introduction. First, let me just give you my conflict of interest disclosures as they apply to this talk. So as Yakira mentioned, together with my partner, Jamie Ferrara, and one of the Mount Sinai biostatisticians, Umid Ozbek, we developed a predictive blood test for GVHD that Mount Sinai has licensed to Biomarker. And I have research support from Biogen for our natalizumab clinical trial, which we'll talk about a little bit. Okay. So I was thinking in this talk, I'd like to go over some of the practical considerations and then talk about the biomarkers and their GI, GVHD biomarkers and their clinical applications. But I don't know if there's a way. I guess somebody just has to talk over me if they want to ask a question. I don't think there's any way to see hands, but I'm very open to having this be as interactive as you would like. And if we just go all the way to the end and you want to ask questions then, that's also fine. But it's fine with me either way. So let's just start with high-level view of graft-versus-host disease. So in GVHD, this is driven by donor T cells recognizing and attacking recipient tissues as foreign. And of course, that's taking place in a more sophisticated way through recognition of either minor histocompatibility antigen differences between the donor and the host, or depending upon the type of match, the major histocompatibility antigens. There are two forms of GVHD that we generally discuss. My talk is going to be very much focused on acute graft-versus-host disease. It typically occurs in the first weeks to months after transplant. The median day of onset is around day 28. You rarely see it before day 14. 90+% will have occurred by day 56 after the transplant. You know, with transplant, we time everything. The day of the transplant is day 0, and then we just work up from there. But there's also chronic graft-versus-host disease, which usually doesn't manifest until months to sometimes years after the transplant, although almost all of it has occurred within, if it's going to develop, it occurs within 18 months, but it can linger for many years once it has occurred. And it tends to be have many appearances as an autoimmune disease, because there's both antibody-mediated manifestations as well as cellular-mediated manifestations. Acute GVHD targets the skin, liver, and GI tract. That definition of the target organs was developed in the 1970s. Many people believe that there are other target organs like the endothelium, possibly the brain, but the definition has not been updated, and this is how people continue to primarily think of acute GVHD as these three target organs. And The symptoms are rash, jaundice, nausea, vomiting, and diarrhea. Each target organ is staged from 0 to 4. So the skin gets a number, the liver gets a number, and the GI tract gets a number based on the severity of the symptoms. And I'll briefly mention, get into a little bit of the detail of the staging system. But then the overall severity grade is a composite of the target organ stages, and grades are from 1 to 4. Of course, if the patient doesn't have GVHD, they would be grade 0. Skin, in the grading system, the skin is underweighted and the liver and the GI tract are overweighted. So a skin stage 3, if that was the only symptom, would be an overall grade of 2. But a GI grade 1, stage 1, would be also an overall grade of 2. So more importance in terms of the severity is given to the visceral organ involvement. So we'll talk about that a little bit more as well as to why. So just in terms of GVHD prevention and treatment, so the prevention is directed at the donor T cells. There's one strategy is just take them out, get rid of them. And there are two primary ways in which that can be done. You can remove the T cells prior to the transplant through graft manipulation. You can run the donor cells over a column that uses antibodies to extract CD3 positive cells or cells that have the alpha beta T cell receptor, and then you're giving a T cell depleted transplant. Or if you see patients, what we are using a lot is post-transplant cyclophosphamide, where 4 days after the transplant, you initiate decent doses of chemotherapy that surprisingly are actually quite well tolerated. And cyclophosphamide preferentially will kill dividing cells, and the cells that are activated and responding to host antigen or that are dividing can actually be killed at that point in time. More commonly, though, that's still maybe 10 to 15% of the transplants. More commonly, it's pharmacologic immunosuppression of the T cells. And the common drugs are calcineurin inhibitors, plus usually in combination with methotrexate, but sometimes with mycophenolate. And the two common calcineurin inhibitors that are used are cyclosporin and tacrolimus. And they're obviously, everything that we do in bone marrow transplant in terms of the drugs is up until very recently has been really kind of copied from the solid organ transplant literature and finding which drugs work for solid organs and for other types of immunosuppression, and then moving them into the allogeneic transplant setting. Despite the prophylaxis, GVHD that requires treatment develops in almost 50% of the patients. It's probably our data from our consortium, it's about 43%, but to make it easy to think about, we'll just say it's about 50. And then the treatment, which has not changed really in 50 years, is high-dose steroids. And about 50%, maybe more, will respond to steroid therapy within 4 weeks. But the patients who don't respond, and it's particularly steroid refractory GI GVHD, accounts for the majority of early non-relapse mortality after transplant. So 80% of the deaths that occur due to non-relapse causes in the first 6 months after transplant can be attributed to GVHD or its treatment, such as immunosuppression resulting in lethal infections. And the majority of that GVHD treatment failure is due to GI involvement of the GI tract. So this is a major, major focus of research in allogeneic transplant, how to improve upon these statistics. There's only been one new FDA-approved treatment in the past half century, and that's ruxolitinib, which is a JAK1/2 inhibitor for steroid refractory GVHD, although it is currently in testing for as primary treatment for GVHD. Okay, so let's move into GVHD pathophysiology. So what's actually occurring? And we tend to, this is a cartoon that has been modified a number of times over the year, but it really comes from in the early 90s, a new thinking about GVHD. So from the late 60s to the 90s, the way people thought about graft-versus-host disease was this: it's all about the T cells. So in this last stage where you're getting, I'm trying to get my mouse to move. In the last stage here where you're getting the tissue damage, you have these activated T cells, and they're reacting to the minor histocompatibility antigens and killing them. But a big breakthrough came with this conceptual paradigm shift, which is that the events that culminate in the graft-versus-host disease manifestations, which I mentioned, you know, they start to appear around 14 days after the transplant in those patients who get it. Half of the cases have developed by day 28, but it's within hours of the transplant that the cells are starting to get activated and respond. And why is that? Well, the first thing is you go back to the conditioning. So when the patients get at the top of the wheel here, we see that there's tissue damage from the chemotherapy and the radiation that the patients are receiving. And that tissue damage results in a lot of release of danger signals that indicate some sort of breach within the system. And in response to that breach or the release of the breach or the release of the cytokines, what ends up happening is it activates in the second stage the host antigen presenting cells. And this is occurring even prior to the infusion of the transplant. And when those host antigen presenting cells are activated in response to the danger signals, but there is no actual infection, they're just presenting self. But when the donor T cells are infused, they react to the host antigen presenting cells. They recognize the host as being different, and then they go on and start proliferating. And the symptoms don't manifest until later because of the lag time it takes from proliferation or let's say spread to begin and the symptoms to manifest. The coronavirus pandemic has so many similarities, right? I mean, you have the exposures, and then it's weeks later that you have the hospital overwhelmed with surges of patients. And I think you can think of graft-versus-host disease very much in the same way. So we'll swing back to that idea of the damage occurring before the symptoms manifest later when we talk more about the biomarkers. But I thought I'd also show you some of the clinical manifestations. So this is a skin stage 1 rash. This is a child I took care of at the University of Michigan, and he has a very, I hope that's projecting well, he has a very stereotypical rash on the palms of his hands, and palm rashes are pretty uncommon in general, but you can see you should be able to see it's a macular papular rash on the palms, patchy distribution, it's not confluent. And then later, this was now stage 3, which meant it was covering more than 50% of his body, and at his foot, this is a picture taken at the same time. His left foot is just kind of cut off in that middle figure. You can see there's just this very confluent rash on his foot. So when we see a rash like this, even a milder rash, and the patient has GI symptoms, our index of suspicion that the GI tract actually is involved with graft-versus-host disease skyrockets. So skin rash plus GI symptoms is generally going to be interpreted by a transplanter as the presence of GI GVHD, or it's highly likely because we already have evidence that it's in one target organ. But what are we actually seeing with the GI tract? So just to kind of briefly review some of the clinical considerations. So starting with the upper GI tract, upper GI GVHD wasn't even considered part of a possible target organ and wasn't included in the staging systems until the early 90s. The symptoms are nausea, vomiting, anorexia. These are also enormously common in transplant patients just from conditioning regimens, from like the radiation they might have received or the chemotherapy. The presence of infection, narcotic withdrawal, numerous other causes. The official definition requires biopsy confirmation, which should show at the minimum some apoptotic cells on pathology. But many centers choose not to order biopsies for the upper GI tract. This is often, if this is a patient's only symptom, they'll want to treat without doing the confirmatory biopsy. So we developed a system that would allow upper GI GVHD to be considered on the basis of symptoms alone, which has now been adopted as the international standard. And we just put down some minimum criteria for the severity of the symptoms. So the nausea had to be present for at least 3 days. Patients have to be vomiting at least twice per day for more than 3 days. They have to have, if they have the symptom is anorexia, it has to be associated with weight loss and not just anorexia with weight loss due to diuretics. So this was an attempt to try to create, at least, even if the definition is wrong, at least we'll be all doing it wrong in the same way. So the idea was to harmonize the definitions across different centers, because as we're doing clinical research, if one center says the patient has GVHD and the other center sees the exact same patient and says they don't have GVHD, then we're not, we're comparing apples to oranges. So we have to do more apples to apples. Lower GI, obviously, upper GI, despite being the part of the GI tract as a target organ, really does not have any significant impact on long-term outcomes. It's the lower GI GVHD where the problem exists, and there we see that the patients have typically a voluminous secretory diarrhea. It's loose, watery, usually green hued due to the bile just transiting very quickly. Again, differential diagnosis would include the toxicity from the conditioning regimen. Infectious colitis is very common. The calcineurin inhibitors cause a magnesium leak, so the patients are put on either are often put on oral magnesium supplementation, and of course that can act as a laxative. Patients who have not been eating during the transplant can have a refeeding syndrome, and then mycophenolate is a big issue in that not only can mycophenolate cause diarrhea, but it can also create histologic changes that look very similar to graft-versus-host disease. So it can be quite challenging to separate out, since many of these things are occurring at the same time, to figure out what's really going on, and a lot of clinical judgment is used. And of course, the common infections are things that we would typically be familiar with: C. diff, rotavirus, norovirus, adenovirus, and then CMV. And all the first four are can be tested for with standard infectious workup like a BioFire, but one of the real benefits in scopes is being able to do the biopsies for CMV, because otherwise it can be missed. The workup, as I mentioned, is this infectious workup with the scope, and then it's important to understand that the histologic grade that is provided by the pathologist does not correlate well with the clinical severity. And negative tissue biopsies are common when disease is present. There hasn't been any standardization of where to biopsy, how many biopsies should be obtained. It varies from gastroenterologist to gastroenterologist what they do. Probably 10 to 15 samples is probably standard. And then when I show you this, the histologic grading system, some of that is also not standard. It's all semi-quantitative. Staging has to be done. The GI staging of the symptoms has to be done based on diarrhea volume, not stool volume. As we were developing our staging system, we realized that people who are often writing the notes don't understand and are not well trained in how to stage lower GI GVHD. For example, we had a patient on a clinical trial from City of Hope, and they were reporting that they were staging them as having GI GVHD and on the basis of the number of frequent bowel movements, but they were formed. So that should not count. So part of it is instructing the clinicians not to quantify anything other than the liquid volume. As everybody knows, it's difficult to get good quantification in the hospital, so we worked out that a a non-quantified episode of diarrhea is an average of 200 cc's. So we can make it how many times did you have diarrhea, multiply that by 200 to get the volume math. And then bleeding in the stool is a sign of the most severe GVHD, and if it's grossly bloody, the volume doesn't matter. It's the most severe. But of course, you have patients with hemorrhoids who have streaks or flecks of blood, and that should not count as to upgrade the patient to stage 4. Okay, so what about this secretory diarrhea? Well, it's this immune-mediated destruction of the mucosa that leads to failure of fluid resorption, and it's especially takes place in the ileum, which is an area that is generally not biopsied. And what happens is destruction of the brush border and loss of the disaccharidase enzymes causes this osmotic effect due to the passage of undigested carbohydrates. And that leads to dysbiosis with loss of bacteria that metabolize the luminal polysaccharides. And you then get the loss of tight junctions from inflammation, which leads to loss of proteins that draw in the fluid with oncotic pressure gradients. So as a result, you have this secretory diarrhea. So even if the patient is NPO, they can still have large volumes of diarrhea. And conceptually, well, let me just move past, and we'll just kind of dispense with the grading system. So the last thing here is just, this is the actual, and since you're recording this, you can refer back to this slide if needed. But the key points here are, one is a patient can have up to 500 mLs of diarrhea per day, which is not normal, but that would still be a stage 0. Stages 1 through 3 for lower GI GVHD staging are just based on these volume cutoffs. And then stage 4, which is assessed based on symptoms, is severe abdominal pain with or without ileus, or grossly bloody diarrhea regardless of volume. And the abdominal pain without ileus is really very subject to the judgment of the person staging the patient. So this is still an area where the subjectivity in GI GVHD staging has not been eliminated, and which makes the whole area of biomarkers so much more important, where if we can provide a more accurate measure of an accurate way to stage the severity of the disease. Okay, so this is a slide that I have showed to people who are staging. It probably doesn't need to be, maybe it's just for comic relief for a GI audience, but the point here is to train people in how to think of the staging and what to quantify and what to not quantify. Okay, so these are endoscopic pictures from endoscopies. Very nervous showing these pictures to an audience of gastroenterologists, since you can interpret these better than I can. These came from a review article that we wrote with Steve Namagon. And the first 4 panels, A, B, C, and D, are colon biopsies. The first one, these are all patients who actually had GVHD on biopsy. The first panel A is normal appearing colon, but there was GVHD, mild GVHD present on biopsy. In panel B, there's edema and loss of vascularity. And then in panels C and D, these actually also corresponded to severe histologic changes. In panel C, the arrows are pointing to an ulcer and some necrotic tissue. And then in panel D, the arrow is pointing to some plaques. And then the last 2 panels, E and F, are upper GI GVHD, and there's a raised erythematous lesions and erosions present in panel E and F. I think these are both duodenum. There's edema, friability, and loss of vascularity. But the review article from 3 years ago, I think Steve did a really terrific job, and I would encourage you, if you want to learn more, to look at that. Okay, And then here's what you see under the microscope. So in panel A, this is stomach tissue magnified 200 fold. You can see the arrows here are pointing to areas of apoptotic epithelial cells. Panel B is the colon, which has, you can see withered necrotic crypts. And then panel C, which is a more of a wide view of what's occurring. You can see just loss of the crypts. This would be, you know, stage 4 on pathology, and that would be typically associated with. This is probably where the pathology and the symptoms tend to align. When you see this, usually the patient's pretty symptomatic. And then the histologic severity staging is shown here on the right, 1 through 4, based on the degree of intestinal damage. This was developed in 1974. It's like 17 or 19 patients were used to develop the staging system. They didn't say how many biopsies needed to be reviewed. They didn't say how many apoptotic cells per high-powered field would count. It's again, it needs to be updated. I think there was an update to some degree in the last few years, but still there's a real lack of standardization in how GI pathologists grade GI GVHD. So we thought one of the things that seems to be reproducible is the Paneth cell count, and that they do correlate with GI severity. So this was a collaborative project that we did with investigators in Regensburg, Germany, and essentially we looked at the mean number of Paneth cells per high-powered field and correlated that with the clinical severity. And as you can see, there's a big dropout in Paneth cell count as the GI severity gets worse. And that also correlated with treatment response, that the patients who had more Paneth cells were more likely to respond to treatment. And when we just created did a count, mean Paneth cells per high-powered field, if it was less than 4 or greater than 4, we found that the patients with fewer Paneth cells had higher non-relapse mortality. So that Paneth cell counts haven't been incorporated into the staging system, and these were all done from the duodenum, but it helped start us along a path to being able to develop our biomarker approach. Well, I think one of the last slides I have on biopsies is this is a paper that's under review, where we looked at about 1,700 patients, many of whom had biopsies, and we just said, what do physicians do when they get the biopsy results? So if the patient had a positive biopsy, the percent that actually got treated for GVHD, if it was upper GI, was 67%, and if it was lower GI, it was 84%. So even some of the times when the biopsy is positive, the physician doesn't believe it and chooses not to treat. And when it was negative, a third of the patients got treated for with upper GI negative biopsies that didn't show GVHD. Still a third got treated, and half of the patients who had lower GI symptoms with a negative biopsy were treated with systemic steroids. So there's still, physicians do what they're going to do. If the biopsy confirms what they think, they'll be more confident in what they're doing, but they're often not used, they're often ignored in clinical decision making. Okay, so how do we move this on to what we're going to do to help our patients? So I spent a fair amount of time talking about the staging system, and the maximum severity clearly correlates with the likelihood of survival. So stage 4, a grade 4 rather, the chances of death are extremely high, and with grade 0 to 1, the chances of death are much lower. But you don't know the maximum severity until the patient's been treated and you've seen whether they respond. When we actually look at what happens at onset, which is when you need to make the decisions, the onset severity actually doesn't predict outcomes. So this is 300 patients based on their onset severity and what their likelihood of response was, and it didn't seem to be very different based on how they presented. And when we look at their non-relapse mortality, these same patients, it correlates very poorly with onset severity, correlates very poorly with non-relapse mortality. So that takes us into the whole idea of the GVHD biomarker. So we've talked about how GVHD is this immune-mediated inflammatory process that results in tissue damage. And we can detect that the immune activation by measuring inflammatory cytokines that activate the immune system, such as IL-2 or TNF. And we can also detect the tissue damage itself by measuring something like REG3 alpha, which is an intestinal antimicrobial peptide that is released when the GI tract is damaged by immune processes. So this is the work that was done in order to develop the first GI GVHD biomarker. This was 871 patients who were studied, and the first thing you can see here is that the REG3 alpha in patients with GI GVHD is much higher than in patients who don't have GVHD. But of course, from a clinician, that doesn't really mean anything because patients, you don't think a patient without diarrhea has GVHD anyway. So, but there was an additional 52 patients who had non-GVHD enteritis. So these were infectious, mostly infectious colitis, and the REG3 alpha was not elevated. So now we're able to distinguish between diarrhea from GVHD from diarrhea from non-GVHD causes. And then when we looked at patients who just had skin GVHD without GI manifestations, the REG3 alpha was also not elevated. So it was elevated only when both conditions were present. GI involvement with GVHD and symptoms. So we then wanted to develop a scoring system, and this is about, the next part's going to be on how we develop the biomarker test. So we started with, back in 2015, with several validated GVHD biomarkers, TNFR1 and interleukin-2 receptor alpha, which are markers for systemic GVHD, Elephant, which is a skin GVHD specific biomarker, REG3 alpha, and then ST2, which is the receptor for IL-33, and when it's solubilized, it's probably been, IL-33 is bound to the target, and then it's now released into the circulation, and that also seems to be primarily from the gastrointestinal tract. None of these individually could predict outcomes across different practices and patient characteristics. So we had the hypothesis that we could create a panel of biomarker concentrations at GVHD onset that could overcome a center effect and stratify patients for risk of non-relapse mortality at 6 months. We chose non-relapse mortality at 6 months because it's subjective, and you don't have to deal with the vagaries of people staging patients differently. So we had a training set of 328 patients from 2 centers, Michigan and the University of Regensburg, and they had GVHD grades 1 through 4 and a research sample. And then we tested every combination of the biomarkers that I previously listed, and we then used a statistical method called competing risk regression, and we found that algorithm that used 3 biomarkers, SD2, TNFR1, and REG3 alpha, was the best model. And you can see that 2 of the 3 biomarkers are from the GI tract, which fits with the GI GVHD being the primary cause of mortality. And the algorithm produces a probability of non-relapse mortality for each patient ranging from 0 to 1. And then we identify thresholds that we classify patients as into lower, intermediate, or high risk for death. And this work was done when we were still at the University of Michigan, so we called them Ann Arbor scores 1, 2, and 3. And then we then validated the algorithm twice, once in an independent test set from the 2 centers from which the samples were derived, and then in a second validation multi-center from a national trial consortium. So here's how the test works, and this was published in Lancet Hematology. The patients, the Ann Arbor 1 group had low non-relapse mortality, and then we used 6 months as the endpoint. It was less than 10%. And then Ann Arbor 2 came in between. It's about 15% higher. And then Ann Arbor 3, another 15% higher. So, but this is the training set. So of course, if it doesn't work here, it's not going to work anywhere. But then you have to validate it to show that when you apply this to patients whom you didn't use to develop the algorithm, that it still works. So it did in the test set. And then we were very, very happy that it also did in a larger multi-center validation set. So we thought we could now predict non-relapse mortality at the onset of GVHD far better than we could with clinical symptoms alone. Importantly, the Ann Arbor scores didn't predict relapse, so it's really telling us about the GVHD. And when we swing back and say, well, we now want to confirm that the non-relapse mortality is tied to the severity of the GVHD. So this is the proportion of patients who had a complete response by day 28 of treatment by their Ann Arbor score. And you can see that the patients with Ann Arbor 1 GVHD are much more they're less likely to die and more likely to respond to treatment than the patients with Ann Arbor 3 GVHD, which of course makes sense. And then that was largely validated reproduced in the validation cohorts. So when we moved to Mount Sinai, we needed to rederive the algorithm because the manufacturer of the SD2 assay changed the kit and the numbers didn't work anymore. So we did this, at this point, we now had a much larger cohort. We had almost 1,300 multi-center patients to study. And with the new SD2 assay, which was more sensitive, we were able to drop TNFR1 from the algorithm to accurately and still accurately predict non-relapse mortality. So that's what the blood test uses, is the concentrations of SD2 and REG3 alpha. So it's all now about the GI damage. So how is this actually working? So this is a cartoon that is what we think is occurring. So an activated T cell in this figure has destroyed a Paneth cell. Paneth cells reside next to the intestinal stem cells in the GI crypt, and they're necessary to maintain the intestinal stem cell host health. You can see that on to the right, that is a now unhealthy, dying intestinal stem cell. The mucosal layer has been lost. The bacteria are now penetrating into the system, and both the REG3 alpha and the SD2, which should be maintained in the intestine, are now entering the bloodstream, and that's why we think we're seeing the elevated levels in the serum, even though the source of the proteins is being damaged. So how do we then convert this test into a clinical application? So can we use the biomarkers to guide GVHD? Meaning, can we select a treatment based on a patient's risk, like we do for other diseases? So just as examples, we use a blood test, HIV PCR, to guide antiretroviral therapy. As oncologists, we use the minimal residual disease to guide the leukemia treatment. So as part of our steps to do biomarker-based risk assessment and conduct clinical trials, is we form this consortium, the Mount Sinai Acute GVHD International Consortium, or MAGIC. It's co-directed by Jamie Farrar and myself, and we have multiple centers across the globe. We also have some affiliated centers, including a group in Australia, which is now working with us, but not formally part of the MAGIC consortium. And this is where we're both studying graft-versus-host disease in observational trials and conducting our clinical trials. So let's just talk about high-risk GVHD. So I've already told you that the deaths in high-risk GVHD are mostly due to steroid refractory GVHD, that the symptoms at onset do not predict who will develop steroid refractory GVHD. but that patients who have high-risk disease, which we would say is the Ann Arbor 2 and 3 group combined, they're the ones who are more likely to develop steroid refractory disease. And our hypothesis was that more intensive treatment before the disease, before the patient has declared that they don't respond to steroids alone, would improve outcomes. So we felt we could identify the patients, but we needed a treatment. And we thought, what could we use to treat? So as you, I'm sure all know, the alpha-4 beta-7 integrin expression is increased well, you may not know it's increased in acute GI GVHD, but the alpha-4 beta-7 integrin expression is necessary for the T cells to adhere to the GI endothelium and then traffic into the GI tract. And this is a figure from a paper from Yi-Bin Chen that shows the increased expression in the T cells in patients with GI GVHD. This is both, you see this both after GI GVHD has been diagnosed, as well as you actually see this expression is increased in patients who are still asymptomatic. So we wanted to use a drug that would then target those T cells. The drug is natalizumab, which binds to the alpha-4 component of the alpha-4 beta-7 integrin. It's FDA approved for Crohn's disease. It's also approved for multiple sclerosis, since alpha-4 beta-1 is how T cells traffic to the brain. It's efficacious in active inflammatory bowel disease. I know you don't use this drug much anymore since you have vedolizumab. We would have actually preferred in our trial to study vedolizumab, but Takeda wouldn't give it to us, and Biogen gave us natalizumab. So that's why we're studying this, and we're doing a clinical trial where patients with GVHD at onset, whether they have GI symptoms or not, are being treated with natalizumab and steroids if they have high-risk biomarkers, because the biomarkers are telling us that the patients have intestinal crypt damage, even if they're not symptomatic. And we've been using the term liquid biopsy to describe how we think of the biomarkers as a liquid biopsy of the GI tract. And the trial is nearing completion of accrual, and then we'll analyze the results and see if this is improving outcomes. In the last few minutes, I wanted to discuss just a little bit about some other ways in which we've been thinking of using the biomarkers. One is in treatment response. So usually the clinical trial endpoint for GVHD trial is the response on day 28 of treatment. But if a patient's not responding, you don't wait 4 weeks to intervene. The decisions are made much earlier. And week 1 is a typical decision-making time point where if patients are responding to steroid therapy, the steroids are often tapered. But if they're not responding, additional therapy is often added. And we wondered, well, what can the biomarkers help us? The biomarkers that work at onset, can they help us at one week of treatment and help guide the decisions? So we did a study from our observational database and biorepository where we had 507 patients with GVHD that was treated with systemic steroids, and we divided them into 3 cohorts: a training cohort and 2 validation cohorts. One was patients from 2005 to 2015, and then when we established MAGIC, we were able to get an almost similar sized validation cohort in 1 year. And then we evaluated the clinical outcomes, including treatment response after 1 week. We measured the 2 biomarkers by ELISA, and then we classified the patients into higher, low biomarkers by the algorithm. So this is just the patients who did not respond after 1 week. These are your patients who are early steroid resistant. They have 42% not patients who have failed to respond. They have high mortality. They're steroid refractory. So it's 42% non-relapse mortality. But when we apply the algorithm, we see that they split into 2 distinct cohorts. So we're able to really risk stratify them. So the patients who haven't responded, who would be called steroid refractory, half of them have high biomarkers and they do even worse. But half of them have low biomarkers and they do considerably better. And we then took that result from the training cohort and applied it to the validation cohort. So here in the first validation cohort, you can see again 41% NRM, and it splits in again pretty evenly into high and low biomarkers, and the difference is even more pronounced And then we see the same thing in the second validation cohort. Again, just looking at the patients who were resistant to treatment early. And what we think we're seeing here is that the patients, although these patients didn't respond to treatment, if their biomarkers are low, meaning that they have considerably less GI crypt damage, even if they haven't had the clinical response yet, these are the slow responders. These are patients where you could really probably just stay the course, and they will, if and they don't probably need extra therapy, and then they will still respond. While the patients who have high biomarkers and that they haven't responded and they still have severe damage going on, they are in deep trouble and they need intensification. And then the last part of the presentation is just to talk a little bit about response biomarkers. So the day 28 clinical response is an accepted endpoint by the FDA for primary treatment trials, and it does correlate with long-term survival. But you know, in the modern era, we're really moving towards also having laboratory measures that determine whether a patient has responded to treatment, but there hasn't been any validated response biomarker. And the FDA definition of a response biomarker is it measures a biological response. It has to change from baseline. And we had a hypothesis that the magic biomarkers would more accurately gauge response than clinical symptoms after 4 weeks of treatment because it's a laboratory measure of disease activity. So they do, and I'll show you the data here. So these are patients with Ann Arbor 1 GVHD, and we look at their biomarkers on day 28, whether they're high or not. So these are patients who had low biomarkers at the start of treatment, and 5% of them had high biomarkers by day 28, and they had much worse survival. The patients with Ann Arbor 2, 27% of them more had high biomarkers at day 28 of treatment, and so again, an increase in their biomarkers and relative to baseline. And those patients had poor survival. And then when we look at the patients with Ann Arbor 3, here is the light blue, which is the important. So those are the patients who the biomarkers went down compared to baseline, and they had better survival. So we thought, well, that was helpful in terms of thinking of that we have a response biomarker. And then we looked and compared it directly to the clinical response. So these are the clinical, first I'm showing you the clinical response after 1 week, 2 weeks, and 4 weeks of treatment. And as time goes on, the response is a better predictor of non-relapse mortality. So by 4 weeks, the area under the curve is 0.7, meaning that if the patients have responded, as more and more patients are responding, and that's correlating with those are also the patients who are surviving. But when we look at the biomarkers, they're really superior at every time point. And in fact, measuring the biomarkers after 1 week of treatment is a better predictor of outcomes than at the clinical response at 4 weeks. So we think we're probably going to be moving towards a combination of clinical and biomarker as response endpoints for clinical trials. Okay, so just to summarize, we have a biomarker test that stratifies patients into groups with distinct risks for treatment failure, non-relapse mortality, and survival. And we have clinical trial applications where we can intensify treatment for high-risk patients. We can guide treatment decisions for the early non-responders and avoid unnecessary escalation of treatment in the slow responders, and a novel response biomarker for clinical trials. And then just to acknowledge, I mean, this is obviously team science, not individual science. And my scientific partner, Jamie Farrar, who runs the lab, just want to highlight him, who's this has all been work that we've been doing together for now over 20 years. So thank you. Ready to take any questions you might have.
Thank you so much. What an incredible body of work. And I think one of the messages for us in broad terms is how important it is to define objective outcomes when you want to develop any sort of predictor.
Yeah.
Otherwise, it's extremely hard to do that.
Yeah, I mean, I think, I mean, inflammatory bowel disease, it sounds like you have a pretty complex but clear objective response criteria. But I don't know about other GI diseases.
We do, but we still struggle with it because we don't have a response biomarker that's very good. That's one thing that we really would love to have, much less sort of predictors of response. But even measurement of objectively of what the burden of inflammation is kind of difficult.
Yeah.
For us.
Yeah.
We're stuck using CRP subgrade and fecal calprotect and all of which have different problems.
Well, I know Ryan and John Fred are working with Jamie on reg3 alpha.
Yep, exactly. Any questions from those who are on? It's a very silent group.
I don't know. I hope I described those endoscopy findings correctly.
Yes, you did very well.
I took it straight from the paper.
I thought for sure Noam would say something about Paneth cells.
Actually, I was just going to speak. You hear me?
Yeah.
Okay, great. Actually, I wasn't aware of the Paneth cells. That's really, that's fascinating. Something we want to look at. I don't know if there's any knowledge gap that you can identify there that might give us a head start.
Yeah, well, so the thing about the Paneth cells, which is, it's really, to me, it's very interesting because, for most of my career, I was really focused on the colon because we thought that's where all that's the major source of diarrhea. That's what we can get to, is what you can examine. And you do see Paneth cell metaplasia sometimes, but, there's not too many Paneth cells there. I should have mentioned Paneth cells are the source of reg3 alpha. Mm-hmm. Now, we know from, not me, since I'm not in the laboratory, but from my friends in the laboratory, we know from the mouse studies that the ileum, the ileum is where the disease is most prominent in the mouse, and we think that's probably true in humans as well. And of course, that's where there's lots of Paneth cells. But there probably is a corresponding biomarker that you could get from colonic damage that just hasn't been identified yet. And I think there's reg2 may be produced in the colon. We haven't really looked at that yet. I don't know if there's what the ELISA would be like for that, but there's, it would be good if we could identify a biomarker for colonic damage as well.
Well, Paneth cells are generally limited, in the colon are limited to the right and transverse, proximal transverse colon.
Yeah.
So sidedness is important. There may be more subtle at least the histological marker would be the morphology of the granules in the Paneth cells, which has become important in certain other areas.
Yeah, well, what was interesting about that Paneth cell work was that those were all duodenal biopsies, and the changes in the duodenum really correlated with the clinical symptoms, which was interesting because it wasn't the duodenum was sort of telling us something about that's happening elsewhere as well. It's obviously not just duodenal damage.
I meant to ask another question. Nowadays, most GI pathologists that I know use the NIH grading system, which is much more recent. That's like 2005. And I don't know if you find
that the Schulman paper?
Yeah.
Yeah.
I don't know if you prefer that, if you find that provides better correlations. Or not. It's a little easier. I don't know. It's 6 of one, half a dozen of the other as to which one we use. But in order to at least achieve standardization, we've been trying to use that. It's also a very limited number of grading steps, and from the feedback I have, it also doesn't correlate particularly well.
Yeah, I think that's still the problem, in that the histologic grade. Not only does it not correlate particularly well with the symptoms, but it doesn't correlate that well with the outcomes, unless it's grade 4. Yeah. So it has been very very challenging, and it's also at Mount Sinai, the practice is to do full colonoscopies. At Michigan, they just did rectosigmoid biopsies, and they I don't know that it made that big a difference. And I don't know that I understand, other than looking for CMV, how the decisions are being made. And, you know, at Michigan, everybody biopsied the upper GI tract at the same time as the lower GI tract. And at Mount Sinai, it's been a little bit, I think Steve's has started doing, more recently does, you know, both. But, you know, the approach to GI GVHD from the gastroenterologists has been, you know, pretty variable. And I think that's maybe there just hasn't been enough crosstalk between the transplanters and the gastroenterologists about how we could be more methodical.
Yeah, I think that's a good point.
Yeah, I don't know what you thought about the fact that the biopsy results get ignored so often. That was an eye opener for me.
It's great because it takes the pressure off us. Nobody really cares what we say.
I don't want you to think that, because I know my colleagues.
Back in the early transplant days, they used to hang on every word we said.
Yeah.
When we were doing small bowel transplant, and it was very nerve-wracking. And similarly in GVHD, that's fine. It's gives us something to do without much pressure.
Yeah.
Let's see. So there, Dave Greenwald is texting me saying he wants to ask a question, but for some reason we can't hear you, Dave. But his question is, he wants to ask about biopsy frequency for GVHD.
Like repeating them?
I guess so. I'm not sure if you mean in response to therapy or practically.
So, you know, there was a paper from I'm blanking on the name. It begins with Castillo. It was a Spanish group where they repeated, in patients who still had symptoms, they repeated the endoscopies with biopsies around 4 weeks after the initial. And in a surprising proportion of patients, the repeat biopsy actually changed, the repeat scope changed treatment because something new was discovered. Something that wasn't present on the original scope was discovered, and then treatment changed. They didn't report on whether changing the treatment changed the, you know, what the outcomes were from the treatment change. But, you know, it's really I think a underexplored area of repeating the scopes. I think there's been kind of an all-around reluctance to do it. I think maybe people think the scopes are too invasive or something. I'm not quite sure I get it. I actually think it'd be worth studying. I don't know how much I would do it just as normal clinical practices. I think it would be really a good study to do, which is how often does a repeat scope and biopsy change treatment, and does that then confer benefit?
But
there's so many symptoms.
The Spanish group was doing it over a few weeks.
Yeah, they did it. No, they did. It was just one. They scoped them and then they rescoped them, and it was a retrospective analysis. So, but my interpretation was that they just were comfortable rescoping patients. In Regensburg, they actually scope everybody on day 28, whether they have symptoms or not. And that's been really useful. Their tissue bank is really helpful because you can, look at patients who don't have active GVHD and see what's going on there. So that's been, and they're doing a lot of work now where they're correlating the tissue with the microbiome and urine changes that are also ways you can get a sense of the intestinal diversity.
Yeah, it's another generic message for research, which is protocolization of care makes research much easier, of course.
Yeah,
I understand that some of the pediatricians here will repeat biopsy in just 3 days. I'm not sure if there's any value in that or what the rationale is or how often they're doing that.
I don't know. For what they repeat it for what?
I don't know.
I don't. I mean, me neither.
Not much would change in 3 days, but maybe.
Yeah, I wouldn't think so.
Yeah. All right. Well, I think we're just over the hour. Thanks for one talk. Nice to meet you virtually.
Yeah.
And thanks so much. And maybe maybe we should think of doing exactly the study that you described, which is repeat look and what the value of that is.
Yeah.
We certainly see enough of your patients.
Yeah. Obviously, the funding would be the challenge.
Well, yeah. I mean, part of it could be part of clinical care potentially. So
yeah, it's worth talking about. Okay. Well, thanks very much for inviting me. I enjoyed it. I hope it was useful for everybody, and everybody have a good day.
Thanks so much.
Yeah,
Take care.
thank you so much.